Well, good day, all. It's a pleasure to be here with you. Thank you for joining us for the latest Global Action on Men's Health webinar and the launch of our No Man's Land, How Men Are Considered in Global Primary Healthcare. This work was supported by Apello. Go back to sharing my slides. And I am Dr. Derek Griffith, Chair of Global Action on Men's Health Board of Trustees and a professor at University of Pennsylvania in the Schools of Nursing and the School of Medicine. There we go. Sorry. And also editor-in-chief of the International Journal of Men's Social and Community Health. So just by way of housekeeping, please sign into the chat and just give us your name and organization so we can see who's in the room or who's here. Please use the chat to ask questions, make comments, and so forth. We won't, in all likelihood, have people unmute to ask their particular questions, but we will make sure that I repeat the questions and take them to the panelists when the time comes. So please do take part. Please do offer thoughts, comments in real time as we go forward so we can integrate those into the conversation. The webinar is going to be about an hour, and then following this live event, we will have it posted on the Global Action website and our YouTube channel. Okay, so why are we doing this? Our goal as Global Action on Men's Health is really to change the way that global health policy considers and takes account of the health of men and boys. And over the past year, or two actually now, we've taken a close look at how global policies address men in relation to cancer, mental health, sexual and reproductive health, and this is the fourth of those reports on men's use of primary care. Today on Universal Health Coverage Day, so happy Universal Health Coverage Day, we're looking at how men are treated in policy related to primary health care at the global level. Men's use of primary care has clearly been suboptimal and clearly been a chronic problem that we've talked about for a very long time in the men's health space and just in the healthcare utilization space. Many men avoid or delay presenting to primary health care, resulting in late diagnosis, poor outcomes, and just lower well-being for them and their families and loved ones. And this is particularly true for working age men and for mental health issues. Global Action's policy reports on cancer, mental health, and sexual and reproductive health showed that men are generally overlooked in policy at the international level and often at the national level when those reports were included, when there were national organizations that were content from those were included in the reports. And we wanted to see whether this was the case with primary health care. So our report, No Man's Land, which is published today, explores this issue, and our findings will be presented to this webinar today and will form the basis of future advocacy work for the organization. So just run of show, there'll be a presentation by the report's authors, Dr. Natalie Leon and Professor Christopher Colvin, which will be followed by comments from three experts in the field, and I will introduce them right before we look for their comments. And again, thanks are due to Apello for their support for this project. They've had no influence on the content of the report, but we do definitely appreciate their support. Certainly, please, look to join Global Action or certainly learn more about us at GAMH.org. Certainly, you can join immediately through the QR code that you see on the screen. So to kick us off, we will have presentations by Dr. Natalie Leon. Natalie is a clinical psychologist and a health system and public health research consultant. He has honorary affiliation to Brown University in Providence, Rhode Island, and also works with the South African Medical Research Council and the University of Cape Town. Colleague and collaborator in this work, Professor Christopher Colvin, is an anthropologist and epidemiologist by training. He's a professor in the Department of Public Health Sciences at the University of Virginia, with honorary affiliations at the University of Cape Town and Brown University. So with that, I will stop sharing and turn it over to Chris and Natalie. Natalie and Chris.
Thank you. Natalie's going to share her slides, and I'm going to take you through just a quick context setting for the report. So you'll see the name No Man's Land, the Treatment of Men and Global Primary Healthcare Policy, which is being published today. Next slide. For this presentation, we're going to take you through kind of how we frame the problem, what we tried to do in the report, very briefly on our methods, and we'll spend most of the time thinking about what we found in this process of reviewing policies, and then a little bit at the end about what we can do to address the problem. So I think Derek's already kind of covered some of this, but just to give you a little bit more detail, we're looking at male gender inequity and access to and utilization of PHC services, primary healthcare services. We know that across a range of burden of disease kind of indicators, incidence and mortality, as well as a range of risk factors, there's a male gender kind of inequity that's quite persistent over time. And like all kind of health determinants or social determinants will interact with other social determinants. We see geographic variation and some other forms of subpopulation variation. We in particular see recent increases in LMICs in this inequity. But despite the variation, this is a pretty durable pattern across kind of global health. Here, we also briefly look in the report at some specific evidence around access and utilization barriers for PHC. We have probably the best evidence in areas of TB, HIV, and mental health. And we're interested in looking across the kind of cascade of PHC services, which would include prevention, testing and screening, initiation, as well as kind of retention and care. So the report really begins with an assumption that we need to increase policy attention to address the unmet health needs for men. We recognize that a gender equity approach, which is more than kind of gender sensitive, but looking at kind of built-in inequities and sources of unfairness in public health, that this gender equity approach has been working to address inequities in women's health, but we need to now bring it to bear on the problems of male health needs. And so here, to do this for men's engagement in PHC, we're trying in this report to better understand the gaps in global, not mental health policy, primary healthcare policy, to inform advocacy for equitable prevention, treatment, and care for men. So what we did in the report was to review global PHC-related policy documents to assess the ways that men are currently considered in global PHC policy, and to develop some recommendations for advocacy strategies. And I'll speak a little bit, and Natalie will pick up later also what we mean by a PHC-related policy report. But to gather these, they're not really indexed in the academic literature. These are policy documents of a variety of formats. So we use rapid review methods that focused on engaging with key organizations and institutions in the field, as well as key experts, to try to generate a list of eligible documents. I think we screened about 90 full text documents, and we ended up with about 60 that were eligible. And then, like in a lot of qualitative reviews and in rapid reviews, we selected down from those 60 to 27 to pay most attention to. And we had a framework which was similar to some of the previous reports we did to extract data and to try to pull the picture together using some kind of basically standard qualitative synthesis techniques. So I'll hand over to Natalie now to take over describing what reports we pulled from and to take us through the findings. You're muted, Natalie.
We extracted data from 27 reports, which were mostly on a global, general primary healthcare related policy documents that were global and multinational, and the majority were from WHO, but also others like UN, the UC 23 and OE report. Non-state organization for general PHC policy organization for journalists. One of the concerns that need taken care of in primary care, also have a life course coverage as well. So we had 6 more WHO reports that looked at various areas that are public health concerns, as well as care for the elderly and the health of adolescents. What we wanted to find out was to see to what extent did these reports engage with gender, for the role of gender in primary care needs and access as determinants, etc. But specifically, was the engagement with primary healthcare needs of men in relation to recognizing male needs and health inequities, and or gender responsive interventions for male health needs? What we found was that there was widespread acknowledgement across reports that disaggregated data is important for understanding and addressing health inequities. And in those cases, it was a general referral to disaggregated data across multiple social determinants such as race, socioeconomic, age, sex, and so on. However, few of these reports actually provided sex disaggregated data based on burden of disease distribution, and none of them presented data on actual gender differences in primary healthcare. With the exception of 2 reports that provided more detailed sex disaggregated data, the WHO 2019 primary healthcare report on universal health coverage is a monitoring report, and the WHO 2023 report on the action for the health of adolescents, or the AHA report, were those 2 reports that had more engagement, and I'll spend more time looking at those. One example in the primary healthcare monitoring report is this graph, which talks about, says that although TB prevalence is higher among men than women, men have lower detection and reporting rates in all WHO regions except for 2. And this kind of detailed breakdown is very rare, and it's found only in this report and a little in the AHA report. In terms of awareness of the role of gender, gender is seen among a range of social determinants of health and health disparities in most reports, not exclusively gender, it's usually social determinants. And gender equity is actually also described as an important guiding principle in most of the reports. However, it's interpreted as women's health equity, as illustrated by this quote. Gender equity is especially important. Women and girls cannot access health services they need. Health systems must be gender responsive to meet the spectrum of health needs of women and men throughout their lives. But usually such a report would then go ahead and talk mainly about women inequity. Except for 2 reports, as I've mentioned, the effects of gender on access to primary healthcare and the quality of primary healthcare services was not addressed across reports. Looking at the engagement with primary healthcare needs of men, and we'll spend a bit more time on this, Few reports, 6 of them, did make some reference to men's health needs, but mostly this was reporting sex disaggregated data, and not in much detail at all. Some of this data came from reports on infectious disease, NCDs, mental health, harmful use of alcohol, and also some refer to the health of prisoners, which we took to be relevant to men because of the high prevalence of incarcerated males. However, there was little to no reference to male gender-responsive strategies for prevention, promotion, and care in primary health care. Specifically regarding engagement with men's needs, as I've said, 2 of the reports made explicit mention of male health needs. This was done, however, alongside reference to women's health needs. These reports provided more detailed sex disaggregated data and a little bit of gender analysis, as you can see in this kind of quote. And I'll read. Men with HIV tend to have fewer entry points into health services and access care later compared to women for HIV and TB. This results in late diagnosis, poor health outcomes, poorer treatment coverage, poor retention and care, poor treatment completion, and high mortality rates. This report went further, in fact, and it's quite unique across all of these reports in that it actually, in their content page, addressed gender disparities, which was unusual, and more so actually referred to men's health equity as a particular component of that. As you can see from this content page, they refer to women's and children's distinct needs as well as to men's greater health risk needs. And the report authors themselves recognize this as quite unique and notes in the foreword that for the first time, the report focuses on gender issues, shedding light on gender norms and power influence access to health services. Having the data broken down in the right way is giving us vital insights about who is being left behind and why, and highlighting where more investment are needed. These 2 reports do advocate for the importance of gender-responsive strategies, including for males. As you can see in this definition here, the authors say that gender equity means fair treatment of men, women, and gender diverse individuals according to their respective needs, so they can benefit equally from rights and opportunities. Barriers to access to men's health services is also mentioned in this report. This is a rather long quote, so just the latter part of it's important. It's saying that in addition to sex-based factors accounting for differences in men having higher disease rates, respective gender norms, including harmful notions of masculinity, are also causes, combined with aggressive marketing of harmful products and practices to men. These can increase men's risk-taking and decrease their willingness to engage with health services. And this level of analysis is also rare. With regard to strategies, a couple of strategies are mentioned to address these health needs of men. One is a health systems orientation barrier-related strategy, noting that the orientation of health systems towards maternal and child health services means that men have fewer entry points to health services, reducing their overall access. The neglect of masculinity-related issues and social determinants is also mentioned, noting that addressing masculinities and social determinants of men's health is relatively neglected in global and national health policies, and hence services and programs fail to identify how best to reach men for their health needs, which further reduces their access. With regards to actual strategies that I recommend, this quote refers to modes of delivery of services that are important for improving men's access to services, and they touch on reducing stigmatization for seeking healthcare, setting up clinics that serve only men, and in addition to that, they also talk about men as partners in their participation in their partners as antenatal care, which can increase their entry points to health, which is a familiar thing that we've seen in other reports. The AHA adolescent report talks about gender transformative strategies, and he finds that as talking about fostering healthier, more progressive or modern views of masculinity that are aimed at encouraging kinder, gentler forms of masculinity. And this is sort of going much more beyond what other reports would have said about masculinities. And then finally, with regard to engagement, the monitoring report goes further to actually try and integrate in, to propose a universal healthcare monitoring framework that actually integrates age disaggregated data and sex disaggregated data. And if you look at the bottom of this concept, this framework, they notice there, they say note A is for age disaggregated and S is for sex disaggregated. And across 3 areas of monitoring, they note under service coverage, financial protection, service delivery, and capacity, various indexes, measurements that require age disaggregated data, sex disaggregated, or one or both of those. For example, under service coverage, if you look across to the last column under non-communicable diseases, tobacco use, alcohol use, certain cancers, including prostate and lungs for men, and suicide mortality, all of those areas require sex disaggregated data. When you monitor UHC is what this framework is proposing. And of course, this is very appropriate because men are overrepresented in prevalence in all of those areas. They also talk about the need to have gender distribution measurement of financial protections. And they talk about the sort of the human resource sort of female orientated female orientated profile of health professionals, and also the need to identify gender pay, usually for women. Of note, and to conclude, this framework draws on several SDGs to sort of promote their gender equity perspective. SDG 5, which talk about women's equality and empowerment, but also others, such as, for instance, the last one talks about exposure to harmful products. And those you could potentially then use that SDG to say, well, men's exposure to alcohol and tobacco advertising and, risky work practice and so on, is covered by the SDGs, and those could be then leveraged in a framework like this. So I'll hand over to Chris at this point to talk about where to from here. Oh, sorry, I'm first going to summarize. So a few reports provide sex disaggregated data and none on primary healthcare access. Gender equality and gender responsiveness were considered important guiding principles, but these were mostly interpreted as female gender inequities. Overall, there was little engagement with men's health across reports, except for 2 reports that we talked about. In these reports, the gender lens was applied in a balanced way to both men's and women's health needs, and this allowed the authors then to actually pay attention to men's needs. And then finally, gender mainstreaming is recommended in these reports and some others, but there is little to no reference on actual male gender responsive strategies. And we will now look at what should we do about the problem, and I'll hand over to Chris.
Okay, thanks. So for our recommendations, we used, as we have in some other reports, this Kingdon's 3 streams model of policy windows of opportunity, largely just because it provides a useful way to organize your thinking. And it divides kind of the way to think about the problem into 3 streams. The problem stream is about better understanding what the problem is. The policy stream is about better having a set of policy options on the table when a window of opportunity does open. And the political stream is largely about this kind of external environment, about the rhythms and events and institutions in the political space, and how those can be taken advantage of. So in the problem stream, we're largely talking about trying to build evidence to motivate for and better know which policy options to motivate for. There is a real gap in a lot of areas. And so just gathering, kind of identifying those evidence gaps and gathering evidence is a kind of a broad-based conclusion. I think, though, even if you do have an army of researchers producing evidence, that evidence is going to sit there unused unless it's accessible. And so it's really important to keep the accessibility of evidence, that kind of evidence translation process, not just accessible, but actively translated, really in focus. And in the report, we summarize some really nice recommendations from the WHO's European Men's Health Strategy around trying to make evidence more proactively kind of accessible. In the policy stream, there are a couple things to do. The first is to consolidate and build from emerging best practices for men. Again, in the report, we have an extract from an Australian literature review on health systems access for men and boys, and that provides a list of, in the box, that provides a list of possible types of interventions and policies that have shown some promise. And the fuller review looks at the evidence that's available for those approaches. And part of developing best practices is also collaborating with men's health advocacy groups in a range of different settings and contexts in order to make sure that our interventions are kind of more nuanced and more transferable. So those networks and coalitions are really important for also improving, refining, and making more transferable kind of the policy options we want to propose. And then the second area under policy is to leverage the growing number of national and global men's health policies and the advocates, behind those to help develop integrated approaches. We have several country-level examples of men's health policies. We've got the 2018 WHO Men's Health Strategy, which covers 53 countries. And there's an emerging set of kind of policy solutions at multiple levels coming out of this. And again, in the report, we've got a summary from the European Men's Health Forum, which usefully kind of organizes some of these approaches. Then for the politics stream, this is largely the one that is out of our direct control, although we can try to prepare the ground so that when political opportunities do open up, we are ready to make use of them. And the two areas, I'm not going to talk you through all these bullets, but I'll kind of summarize the two areas here that we think are useful. One is to leverage parallel policy development for women or for men and policy on other health issues. So if we're thinking about men and primary health care, we need to, at the same time, be thinking about other policy processes and opportunities and events unfolding in women and primary health care, as well as men and other health conditions, right? Because we need to be able to kind of leverage and hook on to those opportunities as they come. So that means looking at global health goals, human rights, kind of commitments and legislation, policy developments like the SDG agenda around, in particular around UHC and people-centered PHC, and finding ways to meaningfully build bridges between people working in men's health equity and women's health equity. And ensuring that there's meaningful men's involvement in promoting women's health equity and vice versa, so that these aren't merely kind of opportunistic alliances. And finally, the kind of second area under politics would be to build long-term coalitions and networks with those who are working on issues only indirectly related to primary health care. So again, this is about trying to think broadly and creatively about how the specific problems of men and PHC are relevant to and can be made more visible in a range of other health policy spaces and opportunities and organizations and individuals, so that when there are things happening, when there is a focus one year at the World Health Assembly or in some other space, right, where kind of global policy is being debated. We have already seen how the kind of problem of men and PHC matters to that conversation, and we're ready to kind of make an intervention, and we're not kind of caught on the back foot. So again, this is an area where we don't often have a lot of direct control, but we can do a lot of ground laying for having a greater impact when opportunities do arise. All right, and that'll be, yeah, that's it from us. Just to acknowledge Peter Baker for his support and guidance. Peter and Derek, who are respectively the director and chair of GAMH, for their input, and to Appella, who funded the report. I'll hand back to Derek now for some input from our panelists, I think.
Excuse me. Thank you, Natalie and Chris. It was wonderful. Let me now turn to our panelists. Let me bring back up my slides. I think we need you to stop. There we go. Oops. So we're very pleased to have three expert panelists, commenters on the work that Chris and Natalie just presented. And I'll just talk about them each briefly, and then I'm going to ask each one a question and have them respond. So first, we have Dr. Arnoldas Jurgutis. Arnoldas is a technical officer in the WHO European Center for Primary Healthcare in the WHO Regional Office for Europe. Dr. Catherine Duggan. Catherine is the CEO of FIP, the International Pharmaceutical Federation. And Professor Mehmet Ungan Mehmet is based at excuse me, Ankara University of Medicine and past president of WONCA. And I spelled out what I could find WONCA was. It's there's the long term and the short version. I'm not going to try to read it all, but just so you know what WONCA is, because I was personally unfamiliar. So let me start with a question for Arnoldas. So the question I have for you, Arnoldas, is what do you see from your work in the WHO European Center for Primary Healthcare as a priority for making primary healthcare more gender responsive and accessible for men? And then can you share examples of barriers to men's use of primary care and how they are addressed in the European region?
Thank you, Derek. Thank you. And let's allow me to start, first of all, with sharing acknowledgement to the work done by Global Action on Men's Health from the WHO European Center for Primary Health Care, from all team led by Melita Jakob. And it's really a great contribution to the work done for gender equity and sheds light on men access barriers for to primary health care service globally. So in the WHO European region, this challenge on man access and gender gaps is recognized, and the first report, I think first WHO report, which was addressed to the man health and well-being, and all causes for these gaps, including access to primary healthcare services. Health system challenges were addressed in the report released in 2018, which was initiated by Non-Communicable Disease Division and coordinated by Isabel Jordi from Venice office. So this report was also as a background information for strategy prepared on that. And so we're working with the strategy, but to responding to your question, I combine what we had in guidance, but more with lenses what we see when we work in practice with country support. So first of all, what we see is that is a building awareness of gender gaps among primary healthcare managers and supports them to advance primary healthcare performance and management systems. That was told in the presentation, and thank you that is addressed in the report. And interesting, when we worked with the countries and we meet professionals, for example, primary healthcare nurses who work with patients with NCDs, education, counseling, they report that, okay, out of 10 patients, there is 1, 2 men, sometimes no 1 man per day. But when we put a question to the managers, do you have data, population-based data? They have no data, sex disaggregated data on the visits, on performance outcomes, on health outcomes. Therefore, that was one of high priority, and we had opportunity to train about 20 countries in performance monitoring, where they prioritized different clinical areas, clinical priorities, but always we prioritized gap. And we somehow communicated, and what we learned that always is a lot of priority to maternity, child health, a lot of indicators prioritized for that. Man is behind, so it's not man land, right? And I think the movement little bit was towards the direction that this gender gaps, disaggregation by sex have to be included in monitoring and performance management system. The second, what we learned from evidence, and thank you that you added to this evidence, is what works to get man timely to the services. And we know about these barriers, that man not recognize problems, masculinity issues as root causes. They don't know where to address the stigma to recognize that I'm ill. And all these issues is, of course, that we have to find mechanisms how to get them. And one is what is emphasized also in the report, we highly recognize technology-based solutions. Man like technology. And when COVID lessons, painful lessons, but we also spread teleconsultations opportunities. And we recognize from countries, Baltic countries, especially from Lithuania, we had described vignette, that men start to use more primary healthcare services when teleconsultations were introduced. So we got them to the system. The another is that we have to make gender sensitive campaigns, and we use peers to influence and to be navigators to other, to seek health services. And that works in Kazakhstan very well, also in West Balkans, where is this big challenge to get men into health services, that peers are, especially those who had some challenges, cardiovascular events, that they influence others and getting to their services. And also more flexible hours, because that is, when we're working, we recognize it. Hours and is more for this non-working population, and man is busy. They need to get services as is evidence. So that is another priority in changing. And third, and I think most challenging, which needs more time, that to change primary healthcare providers, professionals, that they, in addition to clinical competences and capacities, have non-clinical capacities to better recognize health-seeking behavior, better recognize expectations and priorities, recognize mental problems, especially for men, which is often hidden, that you need a little bit more different holistic lenses and tailor to individual needs communication, shared decision making. And that is still a high priority, where we have to work together with universities in addressing that. So our, of course, challenges remain, and despite that, we're working fully integrated gender responsiveness practices, primary healthcare system still not possible, not achieved. So work have to be done. We prioritize more work with universities, and we have more and more PhD students engaged in this man issues, and one of that is here participating, I think, from Almaty University, where already did rather interesting qualitative studies on barriers and we are working together, and next year will be high priority to develop some kind of and validate tools for assessing primary healthcare practices on how they address barriers for men to access. And then we, of course, continue to advocating for policies that promotes equal access for men and women, with high priority on inclusivity for all genders and, of course, vulnerable population groups. Over.
Thank you. Thank you so much for that, Arnoldas. Next, we have, again, Dr. Catherine Duggan. Catherine, when we talk about primary care, the focus is almost always on general practice. But what do you see as a potentially greater role for community pharmacies in improving health? And just any other, my second part for you is also any other reactions, thoughts about how you see pharmacy integrating into some of the findings that we've heard from Natalie and Chris about the report.
Thanks so much, Derek, and a huge thank you to yourself and Peter and everyone at Global Action on Men's Health. Great to hear both Natalie and Chris talk today and to follow Arnoldas. So I just wanted to let you all know FIP is a global organization for pharmacy, pharmacists and pharmaceutical scientists. Our vision is for a world where everyone has access to safe, affordable and effective medicines. And we know, particularly since the pandemic, that vision has probably fallen behind somewhat because access to safe medicines really was put under the spotlight during the pandemic. I think it's quite good for us to be thinking about access to health through the lens of both men and women. We all knew, even before today, that men would access health less than women. And in FIP, our focus on gender has been to support women with the responsible use of medicines, particularly knowing that they can be the primary caregivers in communities and in families and in households. And that has brought a big awareness of the fact that that would mean that a man would access healthcare through a woman in his life, potentially, and not empower him to access healthcare. So it's really given us an idea, especially through the pandemic, where community pharmacy in particular were the shining lights in every community. They remained open, they remained accessible. They have that flexibility that Arnoldas mentioned about being accessible after working hours and being accessible without an appointment. So they can be a very good point of access for somebody to ask a question. And I think promoting that more to men in our communities, men in our families, and men in through our professions would be a real priority for FIP. We do that already, but I think an overt communication around this, particularly with regards to things that men find difficult across all cultures to talk about. This could be sexual health, this could be mental health. I think for men, it can be easier to talk about things like, you know, wounds or hearts or, I don't know, things that are less to do with personal feelings or how they are managing their life, or even sexual health, as I mentioned before. They can be difficult for women to talk about as well, but I think it's more evident in men in our communities. We have three things that I can share with colleagues on the call here. We signed ourselves up to Astana in 2018 so that we were positioning community pharmacy and pharmacy more widely as fundamental to achieving universal health coverage through primary healthcare. And Derek, you're quite right to say primary care is predominantly focused on GPs. That's how our healthcare is usually structured. But if we think about pharmacy playing into primary healthcare, then there are ways in which we can even complement the primary care general practitioner, family doctor. And we can do that by being accessible and flexible. We can do that by promoting agendas around safety of medicines. So getting people to talk about their medicines that they're using, the medicines they might be using that are off prescription, over the counter, compared to prescriptions which can interact with each other. And very often people don't regard the medicines they buy in a community pharmacy as a real medicine, or taking natural products. And we would always have a tongue-in-cheek response that arsenic's natural, it's not particularly safe. And we have the idea then that pharmacists can help in the prevention agenda, from self-care all the way through to immunization and vaccination, as well as non-communicable diseases. And of course, we have the 5 big ones, but they tend to be very scary. And in research that we have undertaken, qualitative research, those NCDs can be very scary, particularly to men. They're cardiovascular ones, mental health, cancers, for example. Whereas we can also spot other diseases or help them with considerations around perhaps the less prevalent ones, or the ones that are more associated with age. And if you think about those 3 elements that can form the pillar of primary healthcare, pharmacy can be really front and center to that, and not in any way compete, but in fact complement the role of the family doctor, the GP. We have our development goals, 21 of them, which work on supporting the profession. They work on big issues around healthcare, like communicable diseases and AMR, and then areas that we should all be pretty much engaged with, even if pharmacy can't make the difference, but everybody could, which includes sustainability, equity, access and safety. And I think if we were to work with GAMH in the next year, and with colleagues from WHO and all other stakeholders, it would be to have a focus on equity and equality, GG number 10, but with the lens of men and women as opposed to women only. That's forming part of our thinking. That's forming part of our conversations. And my final point would be, in discussion with the male leaders in community pharmacy globally, they are interested in being figureheads in this conversation. They have said to us, these are leading community pharmacists who are men themselves, they have said, we might be guilty of these very behaviours that we're talking about supporting men in our communities. We might not be having conversations with younger men in our families about mental health, sexual health, understanding that healthcare is accessible to us as a prevention rather than waiting to be ill to access it. So they are very interested in contributing to this, and I'm blessed to work with men in my profession who view this as an equity and equality issue rather than something to be macho about. So we look forward to the next steps, and I hope that's helpful by way of communication and conversation. Derek, thank you so much.
Thank you very much, Catherine. And last but not least, we have Mehmet. Excuse me, sorry. From the primary care perspective, what steps need to be taken to improve men's use of general practice, and how could WONCA play a part in this?
It's a very good question, and very extensive one, actually, to be honest. I have been listening, I would like to not to repeat what has been told until now, but unfortunately, I will repeat some of them. Sorry for that. Of course, improving men's engagement with the general practice requires a combination of systemic change, community involvement, and tailored health services. And WONCA's leadership in family medicine places it in a strong position to influence global practices, educate healthcare providers, and advocate for initiatives that bridge the gap in men's healthcare. By taking a proactive role, WONCA can help reduce barriers and ensure equitable access to health services for men worldwide. So, how can we do that? I think that there are a lot of things, but just generally global advocacy is an important issue for every organization, and it is including also the WONCA Europe. Here we have one principle in our definition in general practice is to give the medical care irrespective of age, sex, and illness. This is our principle. One way, if you look at from one way, it means that we can't take only men or only women, but another meaning is we can cover all of them in an equal way. So those are all talk you already mentioned about those problems, so I will not go in detail, but this is how we look. And this is very important, I think, to create evidences for the general practitioners and primary healthcare workers, because what we know from the project Protect Europe project, in a recent project results, showed us that if you want to convince the public, you have to really work on the primary health care workers, especially the GPs and the nurses are the most convincing one, including the prevention activities, which we really need for men, as I see, from your reports. So I think that will be very good to create some evidences in the general practice by the general practitioners and nurses in the primary healthcare, and to use them to translate those research evidences into the practice of the advocacy for men. So this is how we can go, and we can do that. WONCA Europe has some, it's a huge organization. They have networks which are working only on primary healthcare research or primary healthcare education or quality, whatever. But at the end of the day, if we can find more resources and funds for the primary healthcare research on this subject, I can tell you that WONCA Europe can create good evidences for the primary healthcare workers to convince them and to work during their one-to-one interviews and interactions with the primary in the primary care with their male patients, let's say. So generally global advocacy, research and policy development, and training programs and promote awareness campaigns, contributing to the health literacy work in the WHO especially. So that those will be the directions that we would like to go, actually. So just last one is, I think, we have been really forcing ourselves to collaborate with many strong organizations and like yours, and we are really having a delicious and a fruitful collaboration with those organizations, and I'm sure that we will have with that organization and the other organizations who are in this boat, let's say. But don't forget that, this is not easy because the primary healthcare is overloaded. That means the overload comes to the nurse and to the primary healthcare physician. So you cannot only expect those to educate them because they don't have time to have additional education. So we are creating very short, very, very short educational programs for those who would like to get the, get the training points and the take-home messages. So we can work together to put it into practice, I think. That's the last word I can tell you.
Thank you so much. Let me again say thank you to all three of our panelists, and of course to our presenters, Natalie and Chris, and report writers. Let me turn to, in our last 6 or 7 minutes, questions. The first one, I think, is really a reflection of the limitations of the way that we present data. But for Natalie and Chris, I believe this is, what about men who are men of sex, men, transgender, and or just gay and don't want to have children? How do they factor into the issues that you sort of talked about?
Yeah, I think this is a persistent kind of challenge. One of the temptations is to try to build your work with men through existing kind of services. When we were talking before the call about how in South Africa, a lot of the men's policy is organized around voluntary medical male circumcision and those existing kind of platforms and services. That's understandable from a kind of short-term approach, but it ends up really limiting kind of your imagination of what you can do. I think also, though, there is a underlying built-in dilemma where you want to talk about men as a category, and then you start to focus in on men who are at higher risk, or men who have distinctive experiences or vulnerabilities, or, and there's really good reason for doing that. But then the dilemma becomes that you are, when you're considering the problem of men, it becomes the men in these key populations, for example. And it's not a either or, but I do think it's worth recognizing that there is a built-in kind of tension between trying to look at men as a category, and including men in all of their diversity, while at the same time trying to develop tailored, kind of approaches for those diverse kind of subgroups of men. And you've got a trade-off, right? You've got the more you specialize and focus in, the more impact you make for those groups, and the less you capture broadly. So
yeah, I just want to make sure I clarify. These with the issues that were not necessarily, were these brought up in the context of the reports that you reviewed, or in terms of those particular, that's okay. That's what I wanted to clarify.
This is, I think,
some of the
dilemma. Yeah.
Thank you. No, go ahead. Sorry.
Yeah, this is our sense of the dilemma. I don't think that's this kind of nuance isn't really present at all, I don't think.
Okay, thank you. That's what I wanted to make sure I clarified. Catherine, I believe this question is for you, about the gender breakdown of community pharmacists. And if it's top-heavy male, could this be a detriment to men accessing and utilizing the services of pharmacists?
Well, across the profession of pharmacy, we have about 70% women across the entire profession. And I think that is absolutely reflected in community pharmacy. But what you might find is in countries where you have owners of pharmacies that are pharmacists, you might find a more predominance of men in those pharmacies. And I think what our initial research, so for example, Portugal, Ireland, those countries would have still an pharmacist owner model for independent pharmacies. And in our conversations with those pharmacists, very interesting that they are the people that I was mentioning at the end of my comments, Derek, that they're very keen. They understand that they may have biases, because obviously the people coming into their community pharmacies would be predominantly women asking about family health. And if you don't have a woman in your life, then maybe you're even at a lower accessibility or thinking about your health in a pharmacy. So they're very, very willing to come on board with the idea that a focus on men with a different approach would be warranted and would be exciting in a way, understanding that you can be a pharmacist first, but you're also a man, gave them a real insight into their own health behaviors and the do what I say, not what I do kind of feeling, that everybody has. I think it's very important for us to look at these issues through our own eyes as well, so that we don't become too separated from them. And I think that comes to Chris's point there about you start with men and then you start thinking about all these subcategories of men. You lose sight of men needing health for men. And that's the same, I think, for looking at women through various subcategories as well. And then we start to look at other genders, and it all becomes very boxes with labels, which I know pharmacists love, but it does become a little bit separated. Whereas actually men just need access to health and access to health advice and access to a way in which they can talk about what's troubling them, but also identify symptoms. And all of us need to stand together. With a frazzled workforce, as Mehmet rightly put, primary healthcare following the pandemic has not yet recovered, and it wasn't necessarily in the best place before that. So I think we all need to be stepping into this space to provide good preventative health advice, and the profession is up for it. Thank you.
Well, we're near the end of time. We have literally about a minute. I also want to note there's a comment in the chat from our dear colleague and friend, Alan White, that's noting that this increase in attention to these issues may have been related to the WHO World Statistic that made specific note about the importance of sex and gender and men's risk. Not going to read the full quote, but I did want to make sure I acknowledge Alan's note in the chat. Since we only have about a minute, any final comments or thoughts from any of you as panelists? Yeah, I'll just open it up to you in case I know we're basically out of time, but any just final comments from any of you? Arnoldas, Mehmet, Natalie, Chris? Yeah.
Just make one quick comment. Just picking up on something Catherine mentioned about pharmacies, PHC being more than pharmacies. I think it's really useful, just from a broad point of view, to keep reminding ourselves that PHC means a lot of things. In South Africa, PHC means traditional healers and their integration with biomedicine. It can mean schools. It's quite a broad field, and I think there's a lot of opportunity in a lot of those other spaces. I just wanted to say that.
Thank you. Well, I think that's a great way to close. So thank you all for joining. Thank you for our presenters and our panelists. We really appreciate your contributions to this conversation. And thank you also to the folks, Peter and Jim Pollard and the rest of our team at Global Action on Men's Health, and again to the Pella Foundation. So happy holidays all. We look forward to seeing you in the new year. Take care. Thanks again. Bye-bye.